Who would have thought at the end of the last century that infusion therapy would have become such an important part of the practice of rheumatology as it is today? In fact, if you look at this slide, which is a compilation of data from Senecor, we can see how the growth of infusion practice within the rheumatology office has really blossomed from 1999, where just a few outliers were performing infusion therapy, to currently where almost 75% of all rheumatology practices have performed infusion therapy. At the same time, it is important to note that there are a number of practices who, after beginning to perform infusion therapy in their offices, have for various reasons discontinued this practice. If we look at our current therapies that are available for the treatment of rheumatoid arthritis, we can see that since 1998, when etanercept was introduced, we've had 4 more treatments introduced, 3 of which are infusion therapies for the treatment of rheumatoid arthritis. Currently, infliximab, rituximab, and abatacept are approved intravenous treatments for the diagnosis of rheumatoid arthritis, as well as for other diagnoses in the case of infliximab. These drugs are all used differently. Their duration of treatment is different. The number of doses per year are different. And I think this is all part and parcel of gathering information to be a successful infusion center. There are special issues with regards to infusion therapy. Patient compliance, route of administration, the pre-treatment screening and pre-medication of the patients, the management of infusion reactions, the oversight of patient insurance and reimbursement, the benefits of being able to add clinical research opportunities, and ultimately the ability to become a referral center for infusion therapy. These are all topics that I'd like to address in the next few minutes to try and help enhance your infusion center reach to a level that possibly it hasn't actually quite accomplished to this point. I think the first thing that we need to do is to have adequate space. When we first started utilizing infusion therapy, many of us were using waiting rooms, broom closets, and corridors. Well, obviously, now that the science has become established and is not going away, I think one of the first things you need to do is to create adequate space. Adequate space for the infusion itself, adequate space for the patients and their families, and adequate space for you and your staff to essentially oversee the infusion center and to perform the various activities that are associated with a successful center. You need to have, obviously, an infusion chair. My feeling is that you should have a chair that can be utilized at least twice a day in at least 2 sessions, and don't spare on the chair. I'd like to suggest that you buy a proper infusion chair that the oncologists use. Your patients are not going to come back to you if you put a 250-pound patient in a small, square little chair. Mandatory items that are necessary for an infusion center include IV pumps and a fridge, the availability of oxygen, monitoring equipment, and a crash cart, in particular for rituximab. As far as staffing is concerned, I think you can use either a nurse or a PA as your infusion therapist. I personally like to have a physician on site. I think it makes a big difference in terms of dealing with adverse reactions, interacting with the patient, giving the patient a sense of comfort that the physician is around, and ultimately it enhances the adjustments that are necessary on an ongoing basis in the treatment of rheumatoid arthritis. Don't forget your front office receptionists and your billing specialists, and you certainly have to have a billing specialist who is a specialist in infusion therapy to be successful. As opposed to the haphazard way in which most of us approached infusion therapy in the past, I think we've now reached a level where a clinical protocol and organizational protocols for the process of care is mandatory, and a clinical pathway for your patient's care is, I think, something that is the standard norm for us today. Let's look at what our infusion nurse does. She's responsible for patient assessment, both prior to treatment as well as during treatment, and maybe one of the most important people in our team in terms of making sure that infusion therapy is successful. In addition to that, she is absolutely the one who's going to educate patients. There's a lot of time in the infusion room, and the ability for your nurse practitioner, physician assistant to interact and educate the patient about their disease is, in my opinion, one of the most important benefits of doing in-office infusion therapy with someone who knows something about rheumatoid arthritis. The infusion nurse is going to be very much part of the preparing and mixing of the drug, and then ultimately the hanging, handling, administration of the drug. Obviously, during the course of therapy, she's the one or he's the one who's going to be responsible for the monitoring of any adverse events, the rate in which the infusion is performed, and ultimately, I think, reassuring both the patient and the physician alike that this is a form of therapy that can be done in a very comfortable environment with minimal risk to the patient or the facility. Ultimately, reimbursement is also something that the infusion nurse is responsible for. They need to document all the services performed during the infusion. They need to be able to provide records for the billing department to proceed with collecting the reimbursement for the treatment. And so I think this is a very skilled position that requires a very high degree of know-how, but once it's achieved, this particular individual is someone who I think is a very, very strong leader in the role of infusion treatments. How do we improve the efficiency in your ambulatory infusion center? Well, I think you need to standardize treatment plans. You can't have different treatment plans for different patients. Obviously, you're not going to be there all the time. It's not expected that your infusion therapist adjusts the treatment plans. And I think the patient gets very comfortable coming in knowing that there is a set plan. I think you should designate someone in your office, a specific nurse, to preview orders to make sure that the orders are correct from the physician as well as from the nurse in terms of implementing the orders. Definitely institute a pre-certification process regarding insurance. When patients come into our office, they have been 100% pre-certified or checked to make sure that for that particular day's infusion treatment, the insurance or coverage, however it may be, the patient may be a self-pay in rare instances, but regardless, everybody up front needs to know that coverage is in place for that particular treatment. And probably when you look at the failures of infusion therapies in physicians' offices in the past, the biggest reason for that failure has been the lack of a pre-certification process regarding insurance and reimbursement. At all times, have a copy of the patient's record at hand prior to treatment. I think it's very important, especially in some cases where you may have more than one infusion therapist, to be able to refer to the patient's record on hand and find out any particular idiosyncrasy for that patient. Definitely determine your infusion scheduling far ahead. I think for me, being able to maximize your infusion center is no different to the airlines being able to fill their seats. You don't want empty infusion chairs because of poor scheduling. Likewise, the patients need to be able to know far in advance when their next infusion treatment is. And so what we will do is we will schedule a patient from treatment to treatment. We will call them up, and I think be available to recognize that there's always going to be different reasons, whether kids that are sick, emergencies that crop up, that you will have on a day-to-day basis patients who were supposed to come in canceling. Have a standby list available. There are always patients who will say, if you can fit me in tomorrow, I'd love to come. And this is how you maximize your infusion center to the most optimal fashion. Make sure that there's interaction between your physician and your nurse teams. We schedule routine staff meetings. We talk about problems that have occurred, and I think on a month-to-month basis, being able to sit down with all members of the team once more, including your billing staff, your insurance verifier, your nurse, and your physicians, and really being able to review all the issues that relate to a successful infusion center is something that is a model that oncologists have been doing for a long time, and I think will be very successful in establishing a much more smooth operation in your practices. Here we see a infusion service model. I'm not going to go through this whole slide, but it is in your booklets, and I think it may be something that's a valuable resource for you. And what we've done is it's been broken up into a pre-service section, an intra-service section, a post-service section, and overall it's a guideline to help you pinpoint some of the issues that may be missing from your operation, or in fact some of the points that you may want to just enhance. Many times we're asked, well, what are the benefits of providing infusion therapy in the office for the patient? I really don't think it's a debate. I think it is absolutely 100% better for the patients to be able to come to the office where they are seeing their physician and getting instruction on their treatment. There may be people who disagree with me, but certainly I've listed here the reasons why I believe that providing services in the office is more beneficial for the patient. The patient is going to get far more personalized and expert care. They're not going to have the same kind of wait and registration process that they would have in a hospital facility. There's on-site supervision by the physician and the nurse practitioner or physician assistant. There's enhanced continuity of care. There's a secure and supportive environment. No question, interaction with other patients having treatment has helped my patients feel better about their own treatment, has educated my patients, has created bonds with them to the extent where we'll have patients requesting to be treated on the same days, and it's almost created a sense of camaraderie that let's look forward to our next infusion treatment. Similarly, comfort is, I think, something that the patient finds in their own comfortable environment where they are used to, far more than a sterile hospital environment. The economic considerations for in-office infusion may well be far less onerous for both the patient and the payer alike. For whatever reason, reimbursement is different in the office to what it is in an outpatient facility, and the co-pays may also differ. So I think this is a very important consideration when it comes to the patient's needs. And ultimately, management of adverse events. It would seem to me that a nurse or a physician assistant who is dealing with the same adverse events again and again and again, in conjunction with a physician who's in close proximity, is going to be far better off and far more capable of managing adverse events than a different nurse on a different day who is doing multiple different diagnoses. So I think if you look at the number of adverse events and aborted infusions that occur in an in-office practice environment, this would tend to be less than we would see in a non-specific hospital environment. I think in-office infusion therapy tends to improve the compliance of patients as opposed to when patients are left to administer the therapy themselves. And in fact, if you look at this particular slide, which is a retrospective analysis of claims data from U.S. health plans, we see that if you compare an infliximab group of patients to an etanercept group of patients to simply methotrexate, that more than 80% of infliximab patients were at least 80% adherent to their therapy, compared to slightly more than 2/3 of etanercept patients and less than 2/3 of methotrexate patients. Obviously, there are many variables, but one can speculate that a infusion therapy that the physician controls is going to improve the compliance of the patient, and certainly the ability of the patient to be almost set up for their treatment as opposed to be left to their own devices is going to improve compliance on the former category. What are the benefits of providing biological therapy in the office for the physician? It definitely improves compliance and safety for the patient. It enhances continuity of care. It creates a state-of-the-art rheumatology practice. It enables you to do more types of clinical research. It allows you to become a referral center, and ultimately it allows for the expansion of your practice. What do we mean by risk management in infusion services, and why? Well, you as the physician, as the practitioner, have significant reimbursement considerations. You need to be very conscious of the constraints on drug coverage, the volatility of the cost of many of these drugs, the supplier constraints, the regulations that seem to change more rapidly than the weather, and ultimately your own scheduling considerations. I think one of the very important things that one has to really come to terms with is purchasing options for medications. This is not something we were ever trained to do, and it's something we've had to learn as we've basically been utilizing these new forms of biologic therapy. You can purchase your biologic medications directly from the various wholesale pharmaceutical companies that have been approved. I would strongly recommend that you shop around. These prices do differ, but there are prices that are very close to what you will probably find is your best price. If you do it in this fashion, then you will be responsible for billing the payer for both medication and services. Alternatively, which may eliminate some of your cash flow problems, you can use regional pharmacy vendors to provide you with the drug, and you simply bill for the services of administering the drug. Or you may contract with your managed care companies to perform a service for biological therapy, which is higher than simply line itemizing the service of infusion, and they in turn will still provide you with the medication. I think it's mandatory for you to have your own accountability for these high-cost medications. There's an internal accountability, which is essentially controlling your inventory. You should know how much you have on your shelf, when you need to order new drug, or when drug is not being turned over. You need to track where your drugs are going, and you need to keep an inventory of the number of times that your chairs are filled, and whether you in fact are losing turnover time by patients not showing up, or by you not getting patients into the chairs sufficiently in a regular fashion. There's also external accountability when you need to evaluate the payers. Are they paying? Are they paying you sufficiently? And you need to research your drug vendors to make sure you're getting the best possible price that you can. You absolutely have to be familiar with coding and billing. You have to know the new coding categories that are listed over there. You need to be familiar with the services that you can bill for and should bill for while you're administering the biologic of your choice. There's an infusion code for hydration. There's an infusion code for therapeutic and diagnostic injections. Make sure you're comfortable with the listed CPT codes and the medication codes. One little mistake in a suffix can cost you dearly, and at the end of the day may cost you your infusion center. If you look at the Medicare updates, it's pretty much the same in 2007 as it was for 2006. For Part B drugs, the reimbursement remains at ASP plus 6%, and then the complex codes for your infusion services. Once more, the physicians have the opportunity to purchase drugs and receive payment under this ASP system, or alternatively, obtain drugs from the vendors selected through the competitive bidding process. Don't forget Medicare Part D with regards to self-injectable drugs. I think this is a very significant benefit that's been initiated for our patients in the last year and a half, and will certainly help cover many of our patients when it comes to their personal costs for the injectable biologic therapy. The codes for Medicare reimbursement for in-office infusion therapy are listed there, and you'll see that you should document each hour of service, the codes, and the Medicare reimbursement next to it. And this is pretty compatible throughout the country, but there are some geographic variations that you will see from location to location. This lists the approximate in-office infusion therapy reimbursements and the cost recovery that you're allowed for medications. Most pertinent on this particular slide is to be careful that you are billing for the number of vials and units that you are allowed to bill for, because the drugs differ in terms of the way they come. You could easily see your billing department making a mistake in terms of how they are pricing the different vials and the different units, and this is very, very important for you to be on top of on, I think, a regular basis. There are a number of reasons why claims are denied or not paid or underpaid. Mostly it comes with documentation or lack of documentation due to insufficient or improper diagnosis and codes. Whether the patient's eligible for services being billed needs to be classified. There are certain diagnoses that, while we know that they may well be appropriate in terms of being treated for that diagnosis may not yet be an approved diagnosis by Medicare or one of the other payers. Billing for unauthorized services is obviously going to be an issue, so authorization of every service you provide is mandatory. And ultimately, don't be afraid to try and negotiate a contract that's higher than you were offered by your provider, your payer. Remember that most times they are going to lowball you with their first number, and I think you need to recognize that it's going to cost a lot more for your patients to be treated in a hospital or outpatient environment than in your own office. And finally, your expertise is worth a certain dollar. Don't undersell your own expertise. Key documentation that is required for the office is the patient identity information. We have a picture ID on every patient who comes into the infusion therapy. Make sure that the insurance is not only covered, but that that the patient's copay that they are responsible for is taken care of on each visit. Do not allow their copays to accumulate, because suddenly the patient will be in a position where they can't afford the treatment and you will be stuck for all the treatments you provided. Make sure every day your nurse practitioner does a drug vial reconstitution. The number of vials and lot numbers are very important to make sure that you don't lose control and track of your actual biological medications in inventory. Finally, the infusion service coding and the setup and patient monitoring, all part and parcel of doing this form of treatment successfully. That's an example of an infusion ticket from my facility. You certainly can make your own adjustments, but I think if you look at that infusion ticket, it will give you all the types and levels of services that you may be utilizing, and certainly if it can help you, feel free to use it, adjust it, and take advantage of that. Just as I think an end to this discussion on infusion therapy and the benefits to your practice, remember that it's going to not only help your patients in terms of their treatments, but it's going to allow you to develop other aspects of your practice. You'll become a referral center in many cases for dermatologists and gastroenterologists, sometimes even oncologists who may be small practices who don't want to do infusion therapy. And I think for clinical research, you're going to find that this is going to give those of you who are doing clinical research a significant step up by being able to do infusion therapy for the many clinical research medications that are coming out in the near future, and which Mark Cohen will talk about in his talk. So, in summary, to better manage the development of intravenous biological therapies, rheumatologists may want to consider setting up infusion centers in their own offices. In-office infusion centers provide the potential for increased patient supervision and enhanced patient satisfaction and compliance. In-office infusion centers may benefit physicians through enhanced continuity of care, clinical research, and practice expansion. And developing a critical pathway and an infusion service model may be useful in improving the efficiency of infusion centers in your office.